Your brain, given too much anesthesia, might sound something like this. Does that bother you? Hey, it's Dr Pelosi III, and this is the Top Cosmetic Gynecologists Podcast. Over-medication bothered a graduate of the Stanford University residency program in anesthesiology. It bothered him enough that he decided to do something about it. Something new in the 1990s. Something better. Years ahead of his time. A man with a message and a mission. To keep your brain from sounding like this. Hey, it's Dr Pelosi III, and with me today is the one and only Dr. Barry Friedberg. Barry is a pioneer in the field of anesthesia who has been practicing outpatient surgical anesthesia in Southern California for over 3 decades. He received his specialty training in anesthesiology in Palo Alto, California at Stanford University, where he trained under C. Philip Larson Jr., and where he worked extensively with Norman Shumway's heart transplant team. He subspecialized in open heart surgery anesthesia for 5 years, and then took his talents into the world of outpatient surgery, where he has been innovating ever since. He is the father of propofol ketamine, or PK, anesthesia for intravenous sedation. He is the author of the textbook Anesthesia in Cosmetic Surgery, the first book in the field of cosmetic surgery anesthesia. He is a co-author of Miller's Anesthesia, the most authoritative textbook in the entire field of anesthesia. He is the recipient of a congressional award for his contribution to military anesthesia in Iraq and Afghanistan. And he is the founder of the Goldilocks Foundation, a nonprofit devoted to making brain monitoring a 21st century standard of anesthesia care for major surgery. I met Barry about 15 years ago at a cosmetic surgical meeting in Newport Beach, California, where he was giving a talk on propofol ketamine anesthesia supplemented by monitoring of the brain with a technology called BIS. B-I-S. He explained to me that this method of working with anesthesia allowed him to titrate doses that were just right, not too much and not too little, to eliminate a condition that is referred to as brain fog, which is something that is not benign and has consequences. But as I spoke with Barry, I realized there was much more to the Barry Friedberg world of anesthesia and style of practice. And if all you do is work with traditional anesthesia services, this is a world you haven't even scratched the surface of. But it's extremely relevant to anybody who practices any type of surgery and works with anesthesia, and to any patient who is going under anesthesia. Because to be informed in the availability of technologies and techniques that are going to reduce the risks of anesthesia is something that impacts everybody. Barry, thank you so much for taking the time to be here. I really appreciate this. I know you're a busy guy.
Marco, thank you very much for the honor of being able to participate and reach out to the surgeons and patients with whom you have an interface.
Thank you. Thank you very much. Now, the 3 big pillars of your current practice and of your current advocacy, because you are like a crusader, how do you define them? What are the big 3 that are in your practice right now that you're trying to get the word out to everywhere?
Well, basically, it's what I call Friedberg's triad. It's 9 words that summarize 25 years of my advocacy. And first is measure the brain. Second is to preempt the pain. And last is emetic drugs abstain. Emesis, of course, is the medical term for vomiting. So measure the brain, preempt the pain, emetic drugs abstain. And from there, we can go on and talk about what's relevant for patients and why the interface between patients and anesthesiologists is a constant challenge.
All right, let's talk about measuring the brain. What does that mean, and how is that done?
Well, it's clear that anesthesia is is a field of medicine that specializes in medicating the brain. But prior to the 1996 FDA approval of the BIS monitor, we didn't have any way to directly measure the brain effect or the brain response to anesthetics. And what happens with this technology is the sensor goes on the forehead, which is right in front of the part of the brain that processes pain and the awareness of consciousness, and it connects to a computer which generates a number from 0 to 100. And as you alluded to before, the numbers allow the dose of anesthetic to be not too much, not too little, but just the right, or what I call Goldilocks amount. And I thought using the term Goldilocks was such a clever shorthand because the fairy tale of Goldilocks and the Three Bears was the story of porridge was too hot or too cold or just right, or the mattress was too hard or too soft or just right. And so, but it turns out that there are legions of people who don't know the fairy tale. So I wind up explaining it anyway. So that's where the term Goldilocks comes in, and that is the power of being able to measure the organ we're medicating, which is the brain. Prior to 1996, all we had was your body weight, heart rate, and blood pressure changes, which really are irregularly and unreliably related to what's going on above your eyebrows.
Now, when this technology first came out, how was it calibrated? How do you know that a reading on the BIS monitor correlates with a certain level of anesthesia? How is that number derived? How was it developed?
Well, the algorithm remains a proprietary secret, but the algorithm was developed using over 5,000 patients as a database to try to correlate this. And the fundamental problem with the BIS number is it tells you where the patient was 15 to 30 seconds ago, which is a lot like trying to drive your car with the rearview mirror. The addition of the muscle activity between the eyebrows, the electromyogram or EMG, that real-time signal allows you to look forward in time to see what's about to happen to the patient. And adding that to the BIS makes this device extremely useful and explains why, to this day, only 20% of people are routinely using the BIS monitor.
Now, in what setting is it being used mostly?
Primarily, it's being used in settings where the concern is anesthesia under-medicating, which is the least value. It's routinely used in open heart surgery and frequently in emergency surgeries where anesthetic doses may be less than desirable. But the real advantage of the monitor is to prevent over-medication. In 2000, I published a statistically significant 30% reduction in propofol use when you measure the organ you're medicating, the brain response. So it may not be, the brain fog issue may not be entirely because of over-medication, but we know this one thing is for certain. The administration of anesthetic is never therapeutic. It's only used to have patients tolerate the surgical stress. So the least anesthetic that does the job is the best anesthetic.
Understood. Now, brain fog. Can you explain and describe brain fog, especially for people that are, let's say, patients who never heard the term before and are wondering what this is?
Well, brain fog encompasses things like postoperative cognitive dysfunction and delirium, and ultimately, in rare cases, even dementia. It's basically partly, I think primarily, it's related to routinely over-medicating when you're not measuring what you're giving and you're giving 30% more. Brain fog essentially means you're not entirely oriented to person, place, and time. You're not sure where you are. You can't organize your thoughts. I use the term brain fog instead of POCD because mostly everybody in the lay public understands what it's like to have a foggy brain, especially anybody who's had too much to drink the night before. It's not at all dissimilar to the concept of a hangover, but in this case, it's a physician-administered hangover as opposed to the bartender.
Right. Now, when you're working with medications, are there certain medications that are more prone to inducing breast fog than others? So are there situations where this BIS monitor becomes even more critical?
Well, any medication that's going to alter your level of consciousness, I should not say any medication, primarily propofol, the drug that Michael Jackson's doctor made so famous, and the inhalational agent. I know there's plenty of anesthesia people who'd like to throw me to the dogs, but that's because I challenge fundamental assumptions about what should and shouldn't be done in anesthesia. And that's the reason my work has gained so much notoriety is the current opioid epidemic. 25 years ago, when I stood up and said, ketamine, not propofol, I was regarded as something of a lunatic. But now that ketamine has been rehabilitated in terms of being used for treatment of PTSD and chronic pain, it no longer gets the same eyebrows and look of horror on people's faces. It's still a difficult sell because the reputation of ketamine was based on when it was given as a solo agent. And it really turns out to be the perfect olive for the propofol martini. The benzodiazepines like Valium are not well measured by the biz, but the inhalational agents that are commonly used, fluorane and sevoflurane and desflurane, are measured. The things that primarily act at the cortical level, or the part of the brain above the eyebrows, are well measured by the biz. The benzodiazepines like Valium act at both levels, and so they're not reliably measured by the biz technology. Interestingly enough, using the biz, you no longer need drugs like Valium and Versed to assure that the patient won't remember the experience, because once you know how asleep the patient is, and you have that EMG warning of incipient arousal, or I'm about to wake up, please give me some more drugs, you no longer have the problem of awareness with recall under anesthesia.
Are there any problems with the biz? Does it have to be calibrated from time to time, or is it a pretty sturdy machine if you have one?
The biz is a very vigorous technology. It doesn't require, I guess every 6 months to a year, the company likes to come out and check to make sure everything is going right. But frankly, in the 20 years I've used it, I've never found that to be necessary. It works very nicely. It's not like many other technologies. Very robust, and people complain that the biz costs too much money. The disposable sensor is $20, and sometimes in an office setting where you're not billing insurance, people look and say, well, am I getting some value for dollar? I say, well, it's important if you don't want to over-medicate patients so that they wake up quickly and are able to go home from the office as quickly as possible. This has value in a hospital setting as well as a surgery center setting, because the biz actually allows you to deliver this propofol ketamine without nausea and vomiting and without post-op pain.
Yeah, it would seem that you make your $20 back the moment that it takes you less time to send the patient home.
Absolutely.
Now, when you say the technology is expensive, how expensive would a biz system be for someone who was interested in using one in their practice?
Well, I'm not in the business side of it, but I'm sure the people at Medtronic can provide that information. It's a one-time cost, and then you have the disposable sensor. The last time I looked, I think a brand new biz was about $8,000, but you can't really hold me to that. It may have changed. I don't really have any current market information about that. I have referred people to a site called, there's a marketing site that carries all sorts of things. I'm blanking on the name of it.
Well, we can add it to the show notes afterwards. So when you find it, you can just email it to me.
Well, you know it. I just can't think of the name right off the top of my head.
You're having a little brain fog there.
Brain fog, yes. Well, at 71, I think I'm entitled to a little brain fog. It's okay. But fortunately, the technique is simple. Teaching the technique is very simple, but teaching cooperation is not. It does call for a degree of cooperation not always found in every operating room.
So when you say that, do you mean that the anesthesiologist needs to be a little more hands-on?
Well, the anesthesiologist has to be willing to use the biz technology, which is, of course, you see 4 to 5 do not. And the surgeon has to understand the power of the biz monitor, because typically what happens is the surgeon injects local anesthetic with adrenaline or epinephrine, and that causes the tissues to look white. And surgeons are typically taught that a white or vasoconstricted field means that the patient is numb, and therefore if the patient moves, it must be because of inadequate drugs that the anesthesiologist is given. And what the biz technology teaches us is that vasoconstriction does not guarantee adequate pain relief, and patients who are numb tend to lie still. So what's happened over the years is that when surgeons are persuaded to first re-inject the immediate area, 98 to 99% of the movement stops, which means extra drugs that would have been given when the patient says, I want the patient deeper, don't need to be given. Well, this is a bridge very far for many relationships of surgeon and anesthesiologist. They just say, I don't want to hear about it. I don't want to talk to you. I just, put the patient to sleep and I don't want the patient to move at all. But the reality is the use of muscle relaxants and general anesthesia elevates the risk level much, much higher, especially in cosmetic surgery where we don't have really a medical indication per se to doing these surgeries. So for me, it's very hard to justify the use of muscle relaxants and general anesthesia when all you need is adequate anesthesia, measuring the propofol, and of course the second element, preempting the pain, the use of ketamine to allow the local anesthetic to be put in without letting the patient know that their body is being invaded. Does that make sense?
Yes, it makes a lot of sense. Let's talk about ketamine a little bit, because I know there are lots of doctors out there who have been taught or have been told that ketamine is a dissociative drug similar to LSD and that patients, quote unquote, freak out when they're given ketamine. So I want you to dispel the myth or dispel what causes the myth.
Okay. First, I will tell you it's not similar to LSD. It's actually second generation PCP. In 1958, a drug called Serenil, which was phencyclidine phosphate, was introduced as a complete and total intravenous anesthetic, and meaning you needed no other drugs, and patients lay very, very calm and still when they had it. Unfortunately, 80% of those patients were having wild hallucinations, dysphorias, and flashbacks, so the drug left market very quickly. PCP is known by its initials, or phencyclidine phosphate, known by its initials, and on the street it's called angel dust. So ketamine is really second generation. Angel dust is called Special K on the street. So the reputation of ketamine for all these problems that you illuminate and what people have been taught is based entirely on ketamine being used again as a solo agent. It was an improvement over Serenil in that only 20% of patients were having hallucinations, dysphorias, and flashbacks, but certainly very unsatisfactory for adult patients, which is why ketamine today is primarily used in the pediatric group because children tend not to complain of hallucinations, as well as in the veterinary group because the animals don't complain of hallucinations. Also, the much older population, 70 and up, small doses can be used again without those problems. But again, this completely ignores 25 years of my published work, which says ketamine is useful as an adjuvant, the drug you give as a small addition to the propofol. And part of the reason I got involved with brain monitoring is during the 1990s, as I'm giving this propofol continuously, it's a very expensive drug, and I'm using about, $30 to $50 an hour, so a 4 or 5 hour facelift is a fairly expensive proposition. The surgeons loved the anesthetic, but they kept saying, can't you find a way to do it cheaper? That's what led me into the use or looking at the brain monitor, and unexpected things developed, like the ability to show the surgeon that if the patient moves without the signal from the muscle between the eyebrows, this just means they need more local anesthesia. And without objective information, surgeons were reassured that the movement didn't mean the patient was awake and was feeling it, and they only needed just a little bit more local anesthesia. So the whole idea of my paradigm really came to coalesce with the combination of propofol first, a small dose of ketamine, local anesthesia, and continue to monitor both the level of sleep, hypnosis with the brain monitor, and to know when you need more propofol as opposed to more lidocaine for numbing.
Now, for the lay public out there that listens to this podcast, tell me about the urban myth, or maybe not so much of a myth, that a patient can be paralyzed under general and be awake and can't communicate that they are awake. Is that reality?
It is reality for 0.1% of patients. And the worst that can happen to you under such circumstances is you may, but not always, you may develop post-traumatic stress. The other side of the coin, the over-medication side of the coin, we know that it's published fact that one patient dies every single day in America. Every day, one patient, independent of any other medical conditions they have, but one patient dies every day from over-medication. So if I have to choose between maybe PTSD or being dead, I think I'd rather not be dead.
Right. But if you were using a BIS monitor, you would be able to detect this brain activity on the spot, correct?
You would most likely be able to detect it, yes. Certainly more likely than if you were waiting to see heart rate and blood pressure changes, because the American Society of Anesthesiologists did a study on this very issue, and they found out that 50% of patients who did experience awareness, which was a very, very small number, had no changes in heart rate and blood pressure to let their anesthesiologist know. So, yes, under general anesthesia, especially if the patient isn't paralyzed and that EMG signal is working extremely well, although I must say friends of mine who use muscle relaxants say the EMG persists, and even in cosmetic surgery patients who have Botox in their forehead, the signal is so small compared to the signal that has to be transduced through the bone and tissues of the brain. It's still there. So yeah, awareness under anesthesia with recall is extremely rare. Problem is that the other 99.9% of patients are being over-medicated, and 40% of them have brain fog when they wake up. Mercifully, that brain fog evaporates in hours, days, weeks, or months. The problem is, for a few patients, it never goes away. And there's no fixing it once it goes past a year. In fact, there's no fixing it, period. The only cure for brain fog is tincture of time, as the old general practitioners used to say. So, to me, the reason the Goldilocks Anesthesia Foundation exists is to make brain monitoring the 21st standard of care for major surgery under anesthesia. Not the 5-minute cataract, not the 20-minute colonoscopy, but when you're having surgery, like the prospective patients who might be listening to this podcast, you definitely want to have a brain monitor. And the problem is, when you ask the anesthesiologist if they're going to use it, you typically get the pushback. You say, oh, we don't need that. Your response as the patient is, with all respect, ma'am or sir, it's not your needs we're concerned with. I want to give you the number from my forehead to help give me the best possible anesthetic. To that end, there's a public education book that I wrote back in 2010 called Getting Over Going Under. It's available at GoldilocksFoundation.org. It's a free, no obligation download. There's no request, there's no donate button, and there's no I want your email button. What I ask people to do is download the book, inform yourself, advocate for better anesthesia, and share this information with your friends. The real problem is that 30% less drugs that you need is a major hit to the people who make the drugs, Big Pharma. And what people in the general public don't see and can't see is the millions of dollars the drug companies give the two national anesthesia societies, the American Society of Anesthesiologists and the American Association of Nurse Anesthetists. So these organizations sort of have their hands tied behind their backs. They're not about to advocate for technology that's going to hurt their main financial backers. So that's why I was motivated to start the nonprofit foundation. It's all done with my own money. There's no industry money in there. There's certainly no brain monitor money in it. And that's what I've been doing, and it's been very edifying. And since 2010, I've also given away more than 7,500 hard copies of the book. And when I tell people this, that seems to be the most amazing thing, that you would do such a thing. I said, because I feel very strongly, and I have skin in the game. I think it's really important that people should, industry should make money from providing goods and services, but not when you're hurting people. And my idea of not hurting people is not having 40% of patients wake up with brain fog, or having one patient a day die from anesthesia over medication, which we can avoid using a brain monitor.
Have you developed any super fans in the anesthesia, in the professional anesthesia world?
Yeah, I have at least about a dozen or so fans around the world. One of my biggest fans is a professor in Belgium named Jan Moulier. He goes around the world teaching about opioid-free anesthesia. I have numerous friends and fans in the country, and anybody who reaches out to me, I'm happy to give them a list of names and emails. But it's interesting that 2 years ago, through Outpatient Surgery magazine, I was connected to Dr. Moulier, and he was having an opioid-free anesthesia meeting in Bruges, Belgium, in December 2017. And when he'd been doing opioid-free for 6 or 8 years, and we heard I've been doing it for 26 years, he says, "Oh, you must come and give a lecture." I said, "But Jan, it's 6 weeks away. You already have your speakers lined up." He says, "Never mind. You must come and give a lecture." So I did, and it's on my YouTube channel, Barry Friedberg, MD, along with the opioid-free anesthesia lecture I gave this February in Abu Dhabi and Dubai.
The second part of your triad, first part was measure the brain. The second one was the preempting the pain. Tell me about preempting the pain.
Well, 25 years ago, I should say before 25 years ago, I started this propofol ketamine was an experiment in March of 1992 for the same office that had a fentanyl death in 1990. And so I knew the surgeon from my hospital practice. He trusted me, and he said to me, "You can use any drugs you want, but no narcotics." And because of the reputation of ketamine and the hallucinogenic issue, I was mainly focused on being sure that patients got the benefit of ketamine without the hallucination. It's only in the last 4 or 5 years that I've begun to emphasize the opioid-free aspect, but that's why it's always been opioid-free, and just the emphasis. So the ketamine, prior to 1992, I've been in practice for 15 years, and never once crossed my mind, why did I have to give patients opioids or narcotics when they woke up? And then I saw 50 consecutive patients, not 5, 10, or 20, 50 consecutive patients by early 1993. They all woke up. None of them were sick to their stomach. There was no vomiting, and none of them needed opioids for pain. I was astonished. I was absolutely astonished. To this day, 25 years later, I'm still astonished because using opioids during anesthesia is a more than 100-year tradition in anesthesia. It's really kind of like the flat earth belief. Most of us in anesthesia believe the following 3 things: that surgery is painful, and opioids are painkillers, and therefore all surgery requires the use of opioids. And here I've done 50 consecutive cases with no opioids, and patients didn't have pain. And the more I thought about it, the more I concluded that the reason patients must be having pain after surgery is they must be having pain during surgery, which was what I thought I was supposed to be doing, giving them anesthesia. I said, "Now, wait a second. This is like a profound insight that not only don't the opioids help, but you don't need them in the first place, because the side effect of the opioids is nausea and vomiting." So that's how we got started. And my first 50 cases I presented in the spring of 1993, and because many articles in the literature were always talking about post-op pain and managing nausea and vomiting, I thought, gosh, here I've got the answer to both these great problems that remain a problem. You would think maybe that people would want to hear about that. And I received nothing but excoriating criticism. I mean, you would have thought I was trying to infect the world with HIV/AIDS using ketamine. So between that and the incredible cost of giving continuous proprietary propofol, people just poo-pooed the idea and thought it was ridiculous. And that's really what crystallized my thinking in terms of the need to produce literature that would help other people who had faced similar problems, like giving a safe anesthetic in an office environment. How could we do better? This is out there. It's useful. And on the subject of publishing, of course, most people know, or in the academic world, most people know at least half of the articles that are published are never cited by later authors. So another point of validation is, even if one person writes a publication, publishes a paper after you, and cites your paper, you're already ahead of 50% of the literature. So my articles have been cited in more than 180 different papers and in more than 50 anesthesia textbooks, including the last 2 editions of the #1 textbook, Miller's Anesthesia. Recently, I was notified that my material has been read 10,000 times. So if you want validation for the work, there it is. In 2004, Cambridge University Press was looking for somebody to write and edit the textbook Anesthesia in Cosmetic Surgery. because the textbook had never been written. And they chose me first out of more than 40,000 anesthesiologists because of my reputation in propofol and ketamine. That textbook was published in 2007, and it was translated into Portuguese for the Brazilian market, and then in Chinese for the mainland Chinese market. So along the way, the U.S. military had me give a lecture, and they were kind enough to write a chapter in my book. And I also received the U.S. Congressional Award because the U.S. military uses this technique out in the.
So the military gave you an award. How did you integrate your techniques in the military?
Well, they asked me to lecture at Brooke Army because they were looking for a smaller footprint for mobile anesthesia. And so they were so excited about the idea that they use it now because they don't have to drag anesthesia machines and these large H tanks out to the forward units to give anesthesia for these otherwise young, healthy individuals. And they rarely, a little E-tank of oxygen goes a long way because they usually don't routinely use oxygen as I didn't for many, many years. So it was actually my U.S. congressman who gave me the recognition, U.S. Congressional Award recognition for my contribution to military anesthesia.
Well, congratulations. Now, I see that you're an associate professor at UC Irvine. So are you working with anesthesia residents?
Well, I tried for a year, actually. I actually tried for 10 years at University of Southern California, and I gave up in frustration because I was a volunteer faculty. I'd come up there once a month, and I gave grand rounds for them. And when the residents would ask their attendings, could they do that thing that Dr. Friedberg did, they said, well, you can only do it when he's here. So that was very unsupportive. I talked to the professor down at UCI, University of California at Irvine. He was supportive and suggested that would be good. And I found after a year that it was the same story, that just people resist change, partly because they're unfamiliar with ketamine. And the only thing they know about ketamine is when it's used as a solo agent, not as a small added or adjuvant agent to continuous propofol. They're completely, it's like a foreign world to them, and they don't like to go where they don't know what it means, and they're also unfamiliar or unwilling to use the BIS brain monitor. So it was a tough sell, and after I guess it was back in 2010 or 2011, I kind of went off and just continued to do my own thing. And along the way, I found LinkedIn, which is a wonderful platform. I have almost 15,000 worldwide contacts, and it allows me into the back door of academic anesthesia, even though, I've given grand rounds to numerous academic programs. It's just very, very difficult to break through the mentality that you have to give opioids during surgery. And it's a challenge because people say, if it's so simple, why isn't everybody doing it? I say, my question exactly. It is simple because we come from a place of complexity in anesthesia training. We learn to use lots and lots of drugs. And 15 years ago, I wrote an article for Outpatient Surgery magazine called Minimally Invasive Anesthesia for Minimally Invasive Surgery, meaning the kinds of cases we do in cosmetic surgery don't involve entering the skull or the chest cavity or the tummy cavity. They're superficial surgeries and therefore minimally invasive. And when I tried to explain to one of my anesthesia colleagues about the virtues of using fewer drugs, he said, well, that's great, Barry, but the more drugs I give, the better I feel. And I said, but what about the patient? What about the patient? Didn't matter. And so part of the reason they want to give more drugs is they're not availing themselves of the information from the brain monitor. When you don't know what a change in heart rate and blood pressure means, you want to give more drugs. Whereas with the brain monitor, when you use it along with that EMG signal, you see far fewer changes in heart rate and blood pressure because, all of that stuff happens from the top down, and the other stuff that happens from the bottom up doesn't really matter. It just matters what's going on above the eyebrows. And the ability to know, or as I like to say, to look through the windshield of the car to see where the car is going, to see where the patient's hypnotic level is going. If things are smooth, you keep doing what they're doing. If they're not, you add more drugs. If things are slowing down, you decrease your drugs. So it's a very dynamic. It involves doing something more than, reading the paper and not watching what's going on. And it also involving the surgeon who says, well, I've injected once, it's your problem now. Well, that's an attitude that's not compatible with this kind of technique and this kind of outcomes, because, as I'd like to say, the two main reasons people get admitted to hospital after day surgery are pain and post-op nausea and vomiting. And over my 26 years, I've done more than 6,000 patients, including total body liposuction, subpectoral breast augmentations, full-on abdominoplasties. Not a single patient has been admitted for either pain or post-op nausea and vomiting. There have been no opioid addicts, no opioid overdose deaths, and all patients were discharged from the office to home without need of professional aftercare givers. So I'm saying, I don't know, I'm sure there must be room for improvement in those outcomes, but, I think those are pretty good results.
Right. Now, do you limit your practice exclusively to surgical anesthesia, or do you also practice pain management?
I basically do. I limited my practice to office-based elective cosmetic surgery, which gets us into the other criticism. People say, well, we do real surgery, Dr. Friedberg. We do joint replacements and other things. And I said, well, let me tell you, I had my own hip replaced 12 years ago. And this was back in the days when the standard hospital stay for hip replacement was 3 to 4 days. The only difference in my anesthetic and everybody else's was the 50 milligrams of ketamine that I use 3 to 5 minutes before they gave the skin incision. I had the spinal anesthesia, the sedation with the propofol, the brain monitor. And in the 2 days I was in the hospital, I took nothing for pain. And I asked the nurses, I said, well, when the spinal wears off, you still have to medicate for pain? Oh, yeah, we still have to medicate for pain. And we have terrible problems with nausea and vomiting. So I wasn't sick to my stomach at all. I didn't start taking any pain medicine until 4 days after surgery, and I was back to work at 6 days. So that was one anecdote. My wife, who's had each of her knees replaced on separate occasions and a shoulder replacement, similar stories, that the local anesthesia, plus the propofol monitor with the brain, plus the 50 milligrams of ketamine, 2 to 5 minutes before incision, and she did better than anybody else on the floor, which is floors. They now have floors that have no sick patients, just people who have joint replacements to minimize surgical infections. So there's no question in my mind that any time you violate the skin barrier, the 50 milligrams of ketamine completely fools the brain that the body has been invaded. And therein is the critical issue. Once the brain knows that the body's been invaded, the patient's skin is a lot like Humpty Dumpty's eggshell. Once you fall and break that shell, you can't put it back together again. And that's the basis of preemptive analgesia. Now, when I wrote my textbook years ago, there was a study that looked at 80 different studies of people getting local anesthesia after general anesthesia to see if they got some benefit, and they couldn't find any significant benefit. And I said, well, the reason is that the patient's brain knew that the body was being invaded when the local anesthesia was given, that the inhalational anesthesia, the general anesthesia they were using, didn't block those critical NMDA receptors in the midbrain. So the patient's brain knows that the body's been invaded, and it sets off that whole series, that cascade that we refer to as the wind-up phenomenon. Or why do patients look like they've been traumatized after surgery? Because the brain knows that the body's being invaded, which is the worst possible signal it can get. 50 milligrams of ketamine, 2 to 5 minutes before incision makes all the difference in the world. You don't have to keep giving the ketamine. You don't have to modify the ketamine for body weight. People say, well, why is that? I said, well, basically I've seen 100-pound women and 250-pound men lie perfectly still with the same 50 milligram dose of ketamine. So obviously body weight can't have much to do with it. I use the same 50 milligram dose of ketamine in 7-year-old children and 94-year-old women and have the same effect, immobility in response to local anesthesia injection. But again, this is in the presence of a continuous propofol infusion. One of the YouTube clips that I have is called Going Under with Goldilocks Anesthesia. It's been seen over 74,000 times, and it shows over 2.5 minutes giving itty-bitty doses continuously while you're watching the brain monitor. It's possible to put the patient to sleep, not have to hold the chin up, not have to give supplemental oxygen, and not have to insert an oral airway to maintain the airway, because the muscle tone is being maintained with that gradual approach. So it's a very, very simple technique, and it works so beautifully. And with the brain monitor, it becomes numerically reproducible. In other words, the first 5 years I did it, I didn't have a brain monitor, and I would titrate to loss of lid reflex. When you stroke the patient's eyelashes, they would blink if they were still awake, and loss of verbal response. Mrs. Smith is asleep now. When she doesn't talk back and she doesn't have a lid reflex, then I gave the ketamine. It was reasonably reproducible, but not numerically so. So it wasn't really science, and people couldn't, take it and run. Whereas with the brain monitor, you know that once you've crept down below 75, the patient is asleep, and you can use the ketamine without hypertension or tachycardia. That's rapid heart rate and rapid high blood pressure. And so it's extremely simple. You get the surgeon to inject the local anesthesia, and then during the case, you know how to modify the propofol, and when you need more local anesthesia, and rarely, very rarely, a little more ketamine.
Now, when you say 75, is that the magic number that you usually target when you're using the BIS monitor?
Yeah. That's the magic number to start with giving the ketamine, and then I try to maintain the patient between 60 and 75, which most people will call moderate to deep sedation. General anesthesia is 45 to 60, and below 45, or at least below 40, is over-medicated. So there's really no reason to run the patients deeper, because deeper isn't better. And so the other interesting thing I forgot to mention about the minimally invasive anesthesia article is that it was written for a trade journal, outpatient surgery. But much to my surprise, years later, Sweden's prestigious Karolinska Institute put that article on their website. It's not something you would think an academic department, a prestigious academic department, would do. And so I asked one of my friends about that, and he says, well, obviously the Swedes understand that not everything that's useful is going to be found in a level 1 randomized controlled trial, double blind. That there are things that are useful that you won't find in those kind of trials. Interestingly enough, years ago, back to we ready to move on to the third section yet?
I had one question. There have been drug shortages, and it impacted our office one time for about a month. We couldn't get any propofol, and we had to substitute. What have you found as a suitable substitute for propofol ketamine with a different agent not being propofol?
Well, you can use midazolam, Versed. The trouble with the benzodiazepines, as I said before, is that the BIS doesn't read it real well. It can help. It can help. They have some papers that say it does help, but because it acts at 2 levels and the BIS is only really able to measure the cortical level, the part above the eyebrows, it's very, very difficult. The thing that we did is we sourced our propofol either from Germany or Canada, or we just looked around. I mean, it was a very difficult thing because propofol is a pretty unique drug, and it's really, as I say, it's God's gift to anesthesia because it comes on quickly and it goes away quickly. But another one of the articles I wrote for outpatient surgery said, happy drugs for happy surgery. Patients who are seeking cosmetic surgery are generally looking to improve their personal level of happiness by changing their appearance in one form or another. And the gradual induction of propofol, putting patients to sleep with propofol, gives everybody a nice feeling. And it took me a couple of months doing it this way to realize that people like this drug. It's a feel-good drug. And why shouldn't people feel good? That's what I say. My colleagues who do hospital anesthesia, for cancer and major vascular, there's not a lot of happiness in the hospital, so it didn't endear me. That little piece did not endear me to my friends in the hospital practices.
All right, let's move on to the third part of the triad, which is your abstinence of emetic drugs. Let's talk a little bit about that.
Well, in 1999, Alex Macario at Stanford did 2 scientifically validated surveys. He asked anesthesiologists to list 1 to 4 outcomes they would most want to avoid after surgery, after anesthesia, and then a separate companion study was that he asked patients, to nobody's great surprise, anesthesiologists listed pain as number one. Again, going back to that OMG moment when I saw those 50 patients wake up without opioids who had no pain. It was staggering. Patients, on the other hand, pain came in at number 4. Number 1 for patients is vomiting. Number 2 was gagging on the endotracheal tube. And number 3 was nausea. What do we get from this? We have a real disconnect between people who give anesthesia and people who receive the anesthesia. Worse still, if you look at the post-op nausea and vomiting chapters in Miller's Anesthesia and other textbooks, they're at the end of the textbook, not where they write we should be at the beginning of the textbook. And many times the issue of post-op nausea and vomiting was called the big little problem. And so you say to yourself, why could it be that patients wouldn't view pain as number 1 and vomiting down at number 3 or 4? And the answer in my mind is when patients sign a surgical consent, they have an intuitive understanding that if someone's going to cut them with a knife, they're going to have some pain, right? And what they're trying to tell us is, please don't rub salt in our wounds by making us sick to our stomach or nauseated. Because although nobody dies from nausea and vomiting, you only wish you were dead. So it's a point that's lost on many, many people who give anesthesia. It's just considered, well, it's part of business. But once you stop giving the opioids, the nausea and vomiting disappears. In 1999, my most cited paper showed a post-op nausea and vomiting rate of 0.6% in a group of 1,264 patients who Christian Athel defined as high risk. That what's a high-risk patient? A non-smoking female patient who has history of nausea and vomiting, who's going to have what they call nauseogenic surgery, like cosmetic surgery. And I called him, and we had communication, Christian Athel, very famous guy, the world authority on nausea and vomiting. I said, hey, those are my patients you're talking about. And so as things went along, I asked him, and he wrote a protocol for a formal level 1 study, double-blind, randomized, controlled study, and I shopped it to 7 different universities. Guess what happened? None of them were interested. It was if, not going there. We don't do that kind of surgery. It doesn't matter what kind of surgery. No, we're not interested. So it's not like I didn't try. And over the years, I came to understand that even if I had been able to find some university center to do the study, I was willing to take out a second mortgage on my house to finance the study, but that didn't happen. If that study had ever gotten published, it's another little challenge. The objections would have been the sample size was inadequate, the exclusions were not good, the statistical analysis was not enough. There would be a million. It's just easier to say no to something that flies against your belief. Whereas what I found in people doing cosmetic surgery in the office setting, you're looking for answers. You're in a situation where every outcome is scrutinized. And that's precisely why I know that over that 26-year period, not a single patient was hospitalized for nausea or vomiting or pain, because we're under maximum scrutiny. And there's no way that a patient could have been admitted to the hospital and that not have been a huge embarrassment to the office and something that would have been talked about a lot. So avoiding emetogenic drugs, when I wrote that, I thought that both the inhalational anesthetics and the opioids were the problem. And what I learned from my friend, Professor Moulier in Belgium, is that the inhalational agents are not really the problem. They have virtually no nausea and vomiting using them, but they also use no opioids. So if you're in an office that gives inhalational anesthesia, just do not have any fentanyl or any opioids there. You'll do much better. The things that I've added over the years that aren't really necessary, but I thought would be helpful, was some IV ketorolac, 30 minutes to 45 minutes before the end of the surgery. And I used to give, the second half of my career, I gave 10 milligrams of dexamethasone along with the induction, along with the propofol and the ketamine. But the first 5 years that produced that remarkable nausea and vomiting. I should say about the nausea and vomiting rate, I forgot to say that at the time that that article came out in 1999, the standard published rates for nausea and vomiting ran between 10 and 40%. So this was exponentially better than anything that had ever been published. And unfortunately, since it was in the cosmetic surgery literature, it didn't get a lot of play in the anesthesia journals. And what made up for it was Dr. Apple was nice enough to reference my article in both the 2010 and 2015 editions of Miller's Anesthesia, the #1 most revered textbook in anesthesia. So when I say to people, look, I understand you didn't see the article in the literature, maybe this journal is not in your reading list, but surely if nausea and vomiting was a concern, you would have seen this in two editions of Miller's Anesthesia. There you have it.
That's fantastic. You've shared some amazing pearls. And I think it's very relevant to the cosmetic surgeon to be able to market a package of services and a better experience all around, especially if it's a competitive procedure or a competitive area, to say that the people that have the work done with the anesthesia services that we provide with this type of anesthesia, they come out happy and they don't feel wiped out. They're more ready to go back to work and get on with the show. What would you say to the people that are listening right now that say, hey, this sounds great? They could either be the patient or a doctor with a practice. How do you approach the anesthesiologist? Obviously, you're a professional and you could just directly talk, pro to pro, and they'll listen to you. But what resources or what approach do you think is the best in your experience to break the ice?
Well, it's hard to know whether the harder conversation to have is the anesthesiologist has heard about this technique and wants to induce the surgeon to use it, or the surgeon who's heard about this at one of our meetings and talks to their anesthesia people. I can tell you what I've encouraged surgeons to try to reach their anesthesiologists. Usually I'll say, look, these are our cases and we're doing this together, and I want to try doing this, and I promise that if we follow this, I won't yell at you. Let's do 10 to 20 cases this way. I know this is out of your wheelhouse, but I'm willing to re-inject before asking for deeper anesthesia if the patient moves, and we're very calm about this, and go from there. It's very, very hard without seeing the objective evidence for a surgeon to accept the idea that vasoconstriction doesn't mean adequate analgesia. But like I say, once you have adequate analgesia, 98 to 99% of the patients lie totally still for their surgery. As far as me reaching anesthesiologists, it's been a challenge because, the first question is, well, who are you anyway, Dr. Friedberg? We don't see you in our literature, and we don't see you talking at our meetings. So if it's so good, how come we're not hearing it? And the answer is it's a question of whose ox is being gored. You're not going to see somebody at the Anesthesia Society meetings who's advocating technology that's going to use 30% less drugs because there's an obvious conflict of interest, right?
Right.
And so you do what you can, and what I can is I work the social media, and I reach out to people, patients. That's why the book Anesthesia, Getting Over Going Under exists, and why I feel strongly about letting people know that they need to inform themselves and advocate for themselves, because change is not going to happen. It's a very, very difficult process, even when you've got the goods. You say to people, well, all those people that didn't go to the hospital for pain or nausea and vomiting, that's, it's staggeringly fantastic outcomes. I mean, how much better could you do? But again, it's the old story, well, how come you're not a featured speaker at our meetings, Dr. Friedberg? And, what are they going to do, hurt their main financial benefactors? Not a chance. So and you can see the disconnect between pain being number one for anesthesiologists and vomiting being number one for patients. There's a fundamental disconnect between what each vested interest group has in mind. So between the outdated teaching of ketamine, that it's a bad drug, and those sorts of things, it becomes a very difficult sell, but all I can do is keep trying. And my late mother said I was a trying child, and so I'm still trying as an adult.
Well, Barry, I want to thank you so much for taking the time to hang out with the top cosmetic gynecologists. I'm going to provide links to wherever you want to send my people for more information. You can just email me and I'll include it in the show notes. And once again, keep fighting the good fight. People are listening. The message is getting through, at least to us. Take care.
Well, I'm very grateful for that, but more importantly, I'm grateful for the patients because nobody likes to suffer needlessly, and when it can be done without suffering, it's really a godsend.
Thanks again.
Share this podcast and this website and this blog with the people in your life who you feel would benefit from this information.